Hey guys, I'm Junior and welcome to my YouTube channel. So we are still on gross anatomy, the thorax to be specific. But for today's video, we are going to talk about the pleura. So without wasting much time, you all know how to support me. Click on the subscribe button, turn on the bell notification, like, comment and share. Let's get into the video. Okay guys, so welcome back. So basically, the pleura is like the singular form of the pleurae. Okay, so the pleura basically is like a serous membrane, but it is like in the form of a gland. It's just like you having a mucous membrane, which more or less helps in the secretion of your mucus. So it is a serous membrane that secretes the serous fluid. But since it is at the level of the lung itself, it more or less covers the lung as well as the internal thoracic wall. So that's why the fluid is known as the pleural fluid, but more or less like a serous fluid, which acts as a lubricant to reduce friction between, the visceral and parietal pleura as you are ventilating. Basically, there are two types of pleura. You have the visceral pleura and the parietal pleura. So the viscera is a term related to internal organs within body cavities. So for example, you have the lungs, the heart, the thymus gland, which are within the thoracic cavity. Then you also have the abdominal viscera like the spleen, the liver, the kidney, the stomach, etc., which are within the abdomen. So visceral pleura is like the membrane that is very, very close to the lung. Since the lung is a viscera, so it is very, very, so it covers the whole of the lung and move deep into the fissures. So the fissures are like lines that divide the lung into lobes. It could be superior, middle, or inferior lobe. Okay, so this is the viscera. It covers the whole of the lung as well as the fissures. So on the contrary, you have the parietal pleura. So it's like the serous membrane that lines the internal thoracic wall. So it is somehow away from the lung as opposed to the visceral pleura. So it lines the inner aspect of the thoracic wall or the thoracic cage. But this serous membrane are of different types. That's the parietal pleura, based on the location as well as the surface that it covers. For example, you have the costal pleura. The costal is more or less like a term related to the ribs. So it is like the serous membrane that lines the posterior aspect of the rib, the sternum, and also some fraction of the thoracic spine, the intercostal spaces, etc. They also have the cervical pleura, which extends onto the root of the neck, and hence the name cervical. But the cervical pleura lines the undersurface of a membrane known as the suprapleural membrane or the SIPS. They also have the diaphragmatic pleura that lines the upper or thoracic surface of the diaphragm. They have the mediastinal pleura, as the name implies. It's like the serous membrane, some fraction of the serous membrane that faces the mediastinum itself. So, hence, it is known as the mediastinal pleura. So, these are like the different types of your parietal pleura. But now, between the visceral that lines the whole of the lung and the fissures, as well as the parietal that lines the internal thoracic wall, you have a very, very small space. Okay, it is very, very small, which is known as the potential pleural space. Now, you have the potential pleural space and the pleural cavity. They are somehow different in that the pleural cavity is more or less within the thoracic cavity, which encloses or accommodates the lungs. You have two pleural cavities, the right and the left, okay, that accommodate the lungs. Then now for the potential pleural space, it's like for each lung, you have the potential pleural space between these two serous membranes. That's the parietal and the visceral. So in between, you have this fluid that is being produced by the cells that makes up the membrane, which produce a fluid known as the pleural fluid within the potential pleural space. So the pleural fluid, as I've said initially, is more or less like a serous fluid. Now the difference between the serous and the mucus is that serous is like very, very like fluid in nature. It is liquid as opposed to the mucus, which is somehow thick. So that's the reason why you have the serous fluid between these two membranes, so as to like act as lubricant to reduce friction. So as you are ventilating, that's inspiring and expiring. So you find out that the lung somehow expand towards the inferior aspect of the diaphragm itself. So as it expands, these two membranes move together. So as a result, you have this fluid that, so it's very fluid in short way. It helps to reduce that friction in short way. You will not feel no kind of sensation like pain, you understand, because these membranes consist of like sensory receptors that receive mostly the sensation, mostly the parietal pleura. So you have certain receptors that receive sensation like pain and stuff like that. So if there is some kind of friction between these two membranes, then there will be some amount of pain sensation. So it's very, very important for you to know this potential pleural space as well as the fluid. So from the pleural fluid within the potential pleural space, you also need to know your different recesses within the lungs. Now, a recess is like a space, or it is part of the potential pleural space. It is like a space to which the lung expand as you are inspiring. Now, when inspiring, taking air to the respiratory tract, you find that your inspiratory muscles, that's the diaphragm and the external intercostal muscles, they contract, and in short way, they increase the volume itself. So the ribs somehow expands as well as the thoracic cavity. So as they expand, the lung also expand towards the inferior aspect of the diaphragm. So now that space, so it's like a reserved space to which the lung move inferiorly as you are inspiring. That space is known as a recess. So basically, you have two types of these recesses based on the location. So one, you have the costodiaphragmatic. So as the name implies, costodiaphragmatic. So it's like the recess or like a space between the costal pleura and the diaphragmatic pleura. Okay, and it is the largest. So it is mostly at the inferior aspect of the lung, very close to the diaphragm. So that's one aspect of the recess. We also have the costomediastinal. So costo, the same costal pleura and the mediastinal pleura. So that space between these two pleurae is known as the costomediastinal recess. So these two recesses are very, very important to store the pleural fluid for lubrication. But now there are four types. When I have two lungs, the right and left lung. So for each lung, you have one costodiaphragmatic and one costomediastinal. You have the right and the left costodiaphragmatic and the right and the left costomediastinal recess. So now the largest of all is the costodiaphragmatic recess. So it is the largest, and you have a lot of fluid around the costodiaphragmatic as opposed to the costomediastinal recess. So if there is any kind of analysis, like a medical practitioner, like a doctor is about to perform some analysis, like checking if there is any infections, more or less like pathogens that maybe lead to pneumonia or whatsoever. So that's the most suitable aspect. So that's like one of the clinical correlates. It is very, very important. Okay, so you have people suffering from pleural effusion, maybe as a result of infection. So there will be accumulation of this pleural fluid within that space. So now the volume of the fluid is about 5 to 10 mils. Okay, so if it is above the normal range, maybe let's say for example 300 mils, so that's known as pleural effusion accumulation. So the fluid accumulates in that space. So in short, that's the most favorable aspect in order for the medical practitioner to decrease the volume of the fluid and also to perform some amount of analysis. We also have the costomediastinal, okay, between the costal pleura and the mediastinal pleura. So that's also, you have the right and the left. But for the left, it's somehow larger as opposed to the right. In that, the left lung in relation to the anterior border, so as you are moving inferiorly, you find that the border is being interrupted by a notch known as the cardiac notch. Okay, so it is as a result of the cardiac notch that allows for the increase in size of the left costomediastinal recess as opposed to the right. Okay, but the most favorable aspect for analysis is the left and the right costodiaphragmatic recess. Now, from the pleural recesses, you also need to understand the nervous supply in relation to these membranes, because these membranes are very, very sensitive to some external and internal stimuli. So now, for example, the parietal pleura, since it is somehow away from the lung, so So it is not that too close. It is not very close to the skin, okay, but it is somehow away. So in short way, it can receive your common external stimuli like pain, temperature, touch, pressure, etc. But now since viscera is somehow away, further from the parietal pleura itself, so it's very very close to the lung as well as the fissures. So it is only sensitive to stretch. So there is, for example, as you are inspiring, okay, so you find out that the volume of the lung increases. So as the volume of the lung increase, it stretches out. So you feel this kind of sensations like this. You have certain stretch receptors around that aspect. So the visceral is only sensitive to stretch, but insensitive to like pain, temperature, pressure, touch, etc. So now in relation to the nervous supply, since the parietal is somehow sensitive to this common external stimuli, the coastal pleura is more or less being supplied by a fraction of the intercostal nerve. So you have 11 intercostal nerves or the subcostal nerve, okay? So the upper 6 intercostal nerves supply the coastal pleura. And now for the mediastinal pleura, which somehow faces the mediastinum, is being supplied by the phrenic nerve. Then you also have the diaphragmatic pleura. Now for the diaphragmatic pleura, a fraction of the membrane above or on top of the diaphragm. So that membrane on top of the diaphragm is being supplied by the phrenic nerve, the same phrenic nerve that supplies the mediastinum. But the other aspect of the diaphragmatic, pleura that is at the periphery, meaning at the sides of the diaphragm, is supplied by the lower 6 intercostal nerves. Okay, that's the lower 5 intercostal nerves plus the subcostal nerves. So it is very very important for you to know. In a region, there must be a clinical correlate. So in relation to the pleura, there are a lot of clinical correlates, but one condition you need to take into consideration is a condition known as pleuritis. But now what you need to know in medicine is any condition that ends in itis is an inflammatory condition, okay? So now pleuritis is more or less like inflammation of your pleura. This could be inflammation of the visceral or the parietal pleura, okay? But they are like conditions secondary to the inflammation of the lungs. For example, pneumonia, which is, it could be a viral or bacterial infection that infects the lung itself. And we all know the functional unit of the lung is the alveolus, okay? So if the lung is being inflamed in subsequent times, then the membrane, mostly the viscera that lines the lung, can also be affected. So as a result, that can lead to inflammation of these serous membranes, that's the visceral and the parietal. So, and we all know the function of these membranes. So more or less produce the pleural fluid, which helps to reduce friction and helps in lubrication and stuff like that. So if there is any inflammation, that can, help to increase the friction, which can lead to rubbing between the membranes, and hence you will feel some amount of pain sensation. So it's very very important for you to know. Okay, so that's pleuritis. They also have another clinical correlate known as pleural effusion, as I have enlightened initially. So effusion is more or less like accumulation, okay, within potential pleural space. So it could be as a result of, again, maybe infection or whatever, which can lead to an increase in production of fluid by the cells that make up the membrane. So there is high amounts of fluid than normal, and that's effusion. So since it is within the potential pleural space, and hence in a pleural effusion. So in short, since there is high amounts of fluid within the space itself, and as you are inspiring, the lung expands, moving inferiorly. So meaning the lung will exert some amount of pressure on the fluid. As a result, there will be a decrease in the expansion of the lung, which sometimes can lead to pain, and also there will be a decrease in the breath sound after auscultation. So if you use a stethoscope to auscultate the lungs during inspiration, so you find that for normal people, they are going to hear the sound from the stethoscope itself. So in some of these conditions like the pleural effusion, so since there is some amount of pressure, like a decrease in the expansion of the lungs, so meaning there will be a decrease in the breath sound. So these are like some, symptoms that are related to these conditions. Thank you very much guys for watching this amazing video. So basically in the next video we are going to talk about the lungs, okay? And I guess you can't afford to miss that video. So that's the reason you need to click on the subscribe button. This is like one of the way you can support me out. Click on the subscribe button, turn on the bell notification, like, comment, and share. See you guys in the next video. Peace.